Ewing sarcoma, as you are probably aware, is, it's a fairly unique disease in that it just happens in people. It doesn't really have the direct correlate in animals, so animals don't get Ewings. But in the broader context of primary bone sarcomas, the other most common primary bone tumor, osteosarcoma, we see a lot in dogs, and it behaves the same way as it does in people. And so that's where a lot of the translational oncology's been working. So I think today what we'd like to do is sort of have a little brief introduction, and so I'll just introduce the three main players here today. So there's myself, Dr. Jamie Custis, who's a radiation oncologist and new faculty here, and also did his residency training here, and Anthony Schwartz, who's our PhD student through the School of Biomedical Engineering, and his PhD project, part of it's going to involve the research that was sponsored by Danny's Foundation. So I think what we'll do is we'll give a probably 10 to 15 minute presentation that will sort of hit some of the highlights of the existing sort of work that we've been doing and how the funded research project relates into the larger context. And then we'll sort of break up into probably two groups, and then we'll do a guided tour of the Animal Cancer Center facility, as well as with special attention to the radiation oncology unit and some of the imaging that we use. So before we start this one, I'll just let you do a bit of an introduction.
Sure.
About you.
Again, I'm Jamie Custis, fortunate enough to come here in 2008 as a resident in radiation oncology, also a veterinarian. Was out in private practice and realized that I really enjoyed oncology patients because it was really the best example of where you were treating not only the pet but also the human companion associated with the pet. And I enjoyed those interactions and realized that oncology was the area that I could really utilize those skills and be able to practice at its highest level. Was fortunate enough again to become a resident here in 2008, completed my residency last fall, and was again fortunate enough that they would let me stick around as a faculty member. And so really have kind of followed our experience with canine osteosarcoma and stereotactic radiation therapy, which I'll talk about in a minute, really from the very beginning. And so just very glad to be here, excited about this project in particular, and we'll go ahead and get into kind of the canine aspect of things in the first half, and then Dr. Ryan will come back and talk about the rodent model stuff.
Yeah. I might just quickly add too just a little bit of historical context about the Animal Cancer Center. I know Martha sort of alluded to it already. So Dr. Steve Withrow, who you saw earlier, was the founder of the Animal Cancer Center. And so back in the mid-80s, veterinary oncology didn't really exist. And so he's one of the grandfathers of oncology. So his training is like me as a surgeon. And as many of you know who've been directly affected with cancer, you'll realize that the speciality of oncology is very much a multidisciplinary care. And so the three main ways that we have to treat cancer with surgery, with radiation, and with medical oncology, so chemotherapy. And so where Steve was very insightful is way back in the 80s, he realized that to have a successful oncology service, you needed to integrate all three of those and have them as one service. So as some of you probably know, in the human world, it's still a little bit different. It's very rare to find a truly integrated oncology service. So you'll go and see the surgeon, then you'll go into a different building, you'll see the chemo people, they'll go to a different people to go and get your diagnostic imaging or radiation done. Mm-hmm. Yeah. We're very fortunate here in that we do have a truly integrated service. So each morning, representatives from all three of those specialties at the faculty level, at the resident level, and then the senior students all meet together. We discuss all the cases that are under our direct care in the hospital. Everybody has their chance to say, I think radiation would be better here, I think surgery would be better there, and we can sort of debate the merits of timing and what appropriate treatment would be for an individual patient. Please come in. So Steve was, very visionary in terms of recognizing that back in the 80s, and he's had a number of very productive and very close associations with the human oncology world. He's had a lot of NIH funding. He worked a lot with Dr. Gillette, who was the grandfather of veterinary radiation oncology. And so the CSU Animal Cancer Center has a very long history with this translational research. One of the key relationships he had is with Dr. Ross Wilkins, who some of you may know from the Limb Preservation Foundation and down at St. Luke's. So they've worked together a lot. Dr. Withrow did a 6-month fellowship at the Mayo Clinic, and so he really got things established so that the human MDs sort of recognize the value of the veterinary oncology model. So we'll talk about more of that as we go around in the tour, but that'll sort of set you up with a little bit of the history there. So I'll hand over to Dr. Custis.
So switch places here. So again, this is, as Dr. Ryan alluded, in canine osteosarcoma, it's primarily a tumor of the long bones, so typically going towards the wrist and shoulder, as well as towards the knee, so the distal femur and the proximal tibia. In this case, we have a dog, so you're looking at the forelimb here, you're looking at the wrist right here, and the elbow, and you can see we have an abnormal bone here. We've got bony change as well as a soft tissue component, and that's fairly typical for dogs that present initially. Typically what we're seeing clinically is that they're having some sort of pain localizing to the area. There's oftentimes a swelling, and like I said, there's also concurrent lameness, so oftentimes they're not bearing full weight in that particular limb. In dogs, it typically affects large breed and giant breed dogs, typically with a median age of about 7 years. And also, as we've already talked and discussed, the important role that Dr. Withrow has played, but also I think this picture nicely represents what we're about here, in that our work with our animals and through the vision of Dr. Withrow, we also have that translational ability to apply what we're learning in our canine patients and hopefully help human patients as well. So as Dr. Ryan already indicated, typically our standard of care for dogs with osteosarcoma and primary bone tumors is going to be amputation. And you can see here we have a dog that is post-operative. We have a little drain placed there. Typically dogs do quite well with amputation in that they're able to regain function and adapt quite quickly. Typically by the time they're leaving the hospital, they're able to get around without that limb, without any difficulty. Also, as Dr. Ryan indicated, limb sparing surgery. So we have a radiograph here where we removed a portion of the bone and then placed a stabilization and plating device there to provide support to the bone. Again, this is a surgery that in the veterinary world, Dr. Withrow pioneered with the help of Dr. Wilkins and others on the human side. And as with most patients, typically we're going to be combining either our amputation and limb sparing surgery with some sort of chemotherapy, because one of the things that we see with our canine patients too is that not only do we have to address the local disease, but also there's a high metastatic rate. So preventing and reducing the risk of metastatic disease with chemotherapy is always an important part of our standard of care. Now, stereotactic radiation therapy is a modality that began in the late 60s with a gentleman by the name of Dr. Lars Lexel. He actually was the inventor of the gamma knife. And so the gamma knife was actually 200 sources of radiation therapy that were all pointed very accurately, very precisely at tumors. And typically, initially, it was begun in patients with inoperable brain tumors. So they would actually, what you can't see in this picture is there's a very rigid device that's actually attached to their skull in a number of different points to ensure that the radiation is all focused on the tumor. Very invasive procedure, but this was the advent of giving large doses of radiation therapy in a single treatment. Currently, here at CSU, we are utilizing stereotactic radiation therapy for the treatment of bone tumors. And the rationale is very similar in that we're going to be coming from many different angles around the target or the tumor. We're going to achieve a very high dose of radiation in the center of the tumor, but at the same time, as we get further away, and we'll have some pictures that will demonstrate this in just a second, as we get further away from the tumor, the dose is going to drop off very rapidly so that we can achieve high doses in the tumor, knowing that dose and tumor control go hand in hand. So if we were able to get a high dose into the tumor, we're increasing our probability of tumor control. And at the same time, as we get further away from the tumor, the dose drops off very rapidly so that we can spare the surrounding normal tissue that is usually in very close proximity to the tumor. Thus, if we reduce the dose to the normal tissues, we reduce the risk of side effects that may make this a less than ideal procedure. What we've done here is, because of the fact that, and I'll show you in just a second, we have gone away from an invasive immobilization device and now have non-invasive means of immobilizing our patients. We're able to give multiple treatments over multiple days, meaning that we can actually get more dose into the tumor and subsequently do a better job of sparing our normal tissues. So we're winning on both ends of the spectrum there. And so here you can see the very top left, we have some film that we've exposed to radiation. And you can see in the first film on the left there, we have two beams. We basically treated this film from above and below, and you can see that we have a concentration of dose in the center indicated by that dark blue. But you can also see that there's a lot of dose in this area where we're entering and this area where we're entering as well. But same film, same dose, but by delivering from many different angles around our target, you can see we're still getting that very desirable high dose in the center, but we're getting less dose out at the periphery. And that is actually how we utilize our linear accelerator. This is a variant trilogy that we'll have the opportunity to see in just a minute. And our patients are positioned on the couch, and then we use the head of the linear accelerator to deliver our radiation from many different fields around the targeted lesion. And you can see that represented here in a patient where we're treating the distal radius, so the equivalent of the wrist, where we had our tumor. And you can see each one of these lines represents a field where we're going to deliver a portion of the cumulative dose. And so by coming from many different angles, each one of these fields is delivered individually. So we'll deliver a small amount of dose from here, then we'll move the LINAC head to another position, deliver some dose, and continue all the way around. And as you can see, we're getting that very nice dose distribution that we saw with the film, and we're getting that nice high dose represented by the reds and oranges. And then as we get closer to the skin surface here, that dose drops off very rapidly. So we're able to, again, achieve our two goals of getting dose to the tumor and minimizing the dose to the surrounding normal tissues. One of the ways that we're able to do that is we're able to modulate the dose. So within the head of the linear accelerator, there are a series of 120 leaves, and they're represented by these little blue lines here. And each one of those leaves has its own motor and is capable of moving during the delivery of therapy. And so our planning system, our computer planning, allows us to determine how those leaves are going to move such that we're going to hit our target here, represented in green, but at the same time spare everything outside of that. So those leaves are going to move, exposing the beam, exposing the tumor to radiation dose where we want it, and preventing the dose from being absorbed by literally blocking the radiation in areas where we don't. And that's how we're able to, again, achieve that very steep dose gradient of dose in the center and dose dropping off in the areas where we don't want it. And that's represented here in this slide. This is just a dose color wash there, so we're seeing where the dose is being distributed. And you can see the tumor starting here and going all the way back into this area here.